Hello, Health Variations 3 case study by Elizabeth Allen. The case study I have chosen is Jackson Smith. He's an 18-year-old male admitted to the emergency department with severe breathlessness. Jackson has a history of asthma. His airway, he has severe dyspnea, an inability to speak full sentences, and a wheeze. His breathing is at 32 breaths per minute. He has diminished breath sounds. His x-rays show clear and hyperinflated lung fields. His circulation, his heart rate is 130 beats per minute. He has no disability, no exposure, no fluids, and no glucose. Asthma. Asthma is a chronic inflammation of the airways, manifested by difficulty in breathing caused by the narrowing of the airways. Asthma is characterised by frequent incidences of uncontrollable dyspnea, wheezing on expiration, coughing, and persistent mucoid bronchial secretions. The pathophysiology of asthma. The inner wall of the bronchial tube consists of a mucus layer surrounded by smooth muscle layers from inward to outward. In the asthmatic condition, the innermost mucus layer swells up and surrounds the smooth muscle layers, constrict, causing the narrowing of the bronchial space and a bronchial spasm. Dyspnea. Dyspnea is a shortness of breath or difficulty breathing. Breathing may be shallow, strenuous, or painful. You may feel breathless or have a feeling of not getting enough air. Dyspnea is often a symptom of another disease or an illness. Dyspnea results when there is an imbalance in the perceived need to breathe and the perceived ability to breathe. CO2 build-up and oxygen deprivation is critical in factors that result in dyspnea. Dyspnea results when an inconsistency occurs in the central nervous system between afferent and efferent signaling. As the brain receives afferent ventilation information, it is able to compare it to the current level of respiration by the efferent signals. If the level of respiration is inappropriate for the body status, then dyspnea can occur. The three main components that contribute to this dyspnea are the afferent signaling, the efferent signals, and the central information processing. The central processing in the brain compares the afferent and efferent signals, and dyspnea results when a mismatch occurs between the two, such as when the need for ventilation, which is the afferent signaling, is not being met by the physical breathing, which is the efferent signaling. The afferent receptors allow the brain to assess whether the efferent or motor commands of the ventilatory muscles are effective, meeting the required demands of airway pressure, airflow, and/or lung movement. Breathlessness reflects the relationship of the drive to breathe and how well our respiratory system is able to accommodate this drive. So when a healthy individual exercises, they have an increase in the desire to breathe and an appropriate response from the respiratory system as to how much volume we breathe and how quickly we breathe. In a patient such as Jackson having a severe asthma attack, he has accelerated drive to breathe, going from the brain to the respiratory muscles. But because of the bronchial restriction in his lungs and airways, he can't essentially do the work to match it. Oxygen therapy. Monitoring and documentation of delivery and flow of oxygen is a vital requirement for a target oxygen to be achieved. Hypoxia is a risk factor for poor clinical outcomes. Vital signs, respiratory rate can also predict potential serious clinical outcomes. Oxygen should be considered a drug, prescribed and administered for specific indicators with target oxygen range and regular monitoring response. The target for a patient with severe asthma is oxygen therapy to target an oxygen range of 93 to 95%, as clearly outlined in Between the Flags system. The Between the Flags is a safety net for all patients who are cared for in New South Wales public hospital and healthcare facilities. It is designed to protect these patients from deteriorating unnoticed and to ensure they receive the appropriate care. Managing acute asthma in adults. Following the Australian Asthma Handbook, starting oxygen, as highlighted in purple, is an immediate response to Jackson's severe asthma. The treatment for an asthmatic adult advises that a nasal cannula or other suitable oxygen mask, such as a Hudson mask, is advisable. The oxygen flow should run at a minimal rate of 2 to 4 litres a minute or more to prevent rebreathing of exhaled gases. Saturation should improve and be monitored, and a decreased work of breathing to increase oxygen saturations. Oxygen administration is a key treatment in respiratory care. The purpose is to increase oxygen saturation in tissues where the saturation levels are too low due to Jackson's severe asthma attack. The goal is to prevent hypoxia by maintaining arterial oxygen saturations. Thank you.